program. Thank you, sir.
Thank you very much for inviting me. It really is a very interesting times for all of us, and I can imagine that we all are struggling through this time. I do hope that you're able to see my slides.
Yes, sir.
And you're able to hear me. The idea today is to tell the listeners how to assess for pulmonary hypertension on CT scan. And this is something very, very important. I just going to give very practical clues on how, when you see a CT scan, if a patient comes with pulmonary hypertension, how do you look at them? What do you look for? Okay. And then we're going to look at how to recognize pulmonary embolism on CT scan. So this is going to be the main objective. Recognize pulmonary hypertension on CT scans, look at pulmonary embolism. Those are my two main topics that we're going to be looking at on today's time. The first and foremost thing that one has to do is to look at the CT scan. This is the main pulmonary artery. This is the right pulmonary artery, and this is the left pulmonary artery. And this structure here is the ascending aorta. The main pulmonary artery should be less than 3 centimeters. The main pulmonary artery, when it increases more than 3 centimeters, or if the main pulmonary artery is bigger than the aorta, that is one sign of pulmonary hypertension. The second thing to look for is the size of the right ventricle. This is the right atrium, right ventricle, left atrium, left ventricle. Once the right ventricle dilates more than the left ventricle, that is another feature of pulmonary hypertension. Please do not worry if you cannot recognize the anatomy. I'm going to practically show you 2 cases where you can recognize the anatomy on a CT scan. Finally, what you're looking for is, this is the liver of the patient. If you start to see contrast coming into the liver, which usually means that the contrast has come from the right atria, gone into the IVC, secondary to tricuspid regurgitation. These are the paramount features of pulmonary hypertension. Dilated pulmonary artery more than 3 centimeters, dilated right ventricle in comparison to the left ventricle, and then tricuspid regurgitation. These help us in recognizing pulmonary hypertension. The next thing that we look for is pulmonary embolism. Pulmonary embolism can be acute or chronic that we look at. Acute pulmonary embolism are hypodense or black, central in location, and the blood vessel, the pulmonary artery, becomes bigger compared to chronic pulmonary embolism, where the vessel becomes smaller. Why is it important? It's important to differentiate these because in acute pulmonary embolism, thrombolysis will work, while in chronic pulmonary embolism, thrombolysis does not work, and you have to give them long-term warfarin therapy, and they may require pulmonary endarterectomy. Next thing happens is, as soon as you see pulmonary embolism, acute pulmonary embolism, we have to look for something called as the clot score. What is the clot burden? This will help you in deciding which patients you should thrombolyze, which patient can be managed without thrombolysis. The way we do is, we look at the segments of the lungs. There are a total of 20 segments. Each segment gets given a maximum score of 2 if the blood vessel there is occluded. If it is partially occluded, that segment gets a score of 1. And if there is no clot, the score is given 0. We will again go through this when we see the cases today. The score is calculated out of 40. So let's say there is occlusion in 4 segments. And let's say that will be 4 segments, complete occlusion, 8 will be the score. So the score will be 8 by 40. To get in terms of percentage, we multiply it by 2.5. So 8 into 2.5 makes it 20. So the clot burden becomes 20%. So that's how we would do the scoring for pulmonary embolism, to look for the clot burden. The right heart dysfunction is very, very important, because if you look at the newer guidelines, previously we used to say there has to be a clot burden of 50% to be able to thrombolyze patients. Now the guidelines are different. The guidelines are patients who have right heart dysfunction with pulmonary embolism, or who are sick with pulmonary embolism, and in an acute PE they can be thrombolyzed. So again, Next thing we look for is lung parenchymal changes to make sure that there is a infarct or not in these patients. So how does acute pulmonary embolism appear? This is the main pulmonary artery, right pulmonary artery, left pulmonary artery. And you can see these large black color or hypodense clot, the vessel being expanded. The same one you can see here, the blood vessel is getting expanded. And then you can see these linear areas of filling defects. All of these are acute pulmonary embolism. At the same time, if you remember, I said we measure the pulmonary artery. The pulmonary artery is dilated 3.3 centimeters. The right ventricle is bigger than the left ventricle. And then there is tricuspid regurgitation. All of these put together, it makes it acute pulmonary embolism with right heart dysfunction or features of pulmonary hypertension. Also, look for lung parenchymal changes. Normal lungs, you can see, are black here. And then you see something like this. This is like a infarct, wedge-shaped opacity suggestive of an infarction in that. So when it comes to chronic pulmonary embolism, we are looking at webs. These are linear things. These are not like blobs of defect that we have seen. The vessels become smaller in size and there will be right heart dysfunction. Let's see some of these cases, okay? So whenever you see CT scan, you have to look for pulmonary embolism, and this is what a web looks like. You can see these linear opacities. This is called as the Mercedes-Benz sign. This is like the Mercedes-Benz feature of the car. So this is what a chronic pulmonary embolism looks like. This is very, very important. Again, you can see these webs. These are very different from what we had seen in the previous slides where there were good filling defects. These are webs in keeping with chronic pulmonary embolism. Another case, what happens here, you can see these blood vessels, and then this is a very, very small blood vessel, all again suggestive of chronic pulmonary embolism. You can see this filling defect. It's not in the center of the vessel, but more towards the side of the vessel, suggestive of chronic pulmonary embolism. So this is what an acute and a chronic pulmonary embolism looks like. Now, what I'm going to do is I'm going to just stop sharing my screen and then I'll reshare my screen. And I'm going to show you cases on the real, okay? If you get some cases, if you get to see some images, what is that you're going to be looking at? How does it appear on the images? That is something that we are going to be looking at. So this is one patient who has come in with shortness of breath. I'm hoping that you're able to see the screen. Yeah, okay. So this is a patient and this is the anatomy that we're going to look at. This is the pulmonary artery here. This is the right pulmonary artery that we are looking at. And this is the left pulmonary artery that we are looking at. Remember, simple thing first, we're going to measure the size of the pulmonary artery. So if we measure the size of the pulmonary artery here, the pulmonary artery size is 3.1 centimeters, suggesting that there is pulmonary hypertension. Then we go down, this is the aorta. As we go down, we are looking for the right ventricle and the right atria. This is the right atria. This is the right ventricle. So anatomically, now we are very clear. This is the right ventricle. This is the left ventricle. You can clearly see that the right ventricle is much bigger than the left ventricle. So we can measure it here, 4.9. And then we can measure the left ventricle here. And we can see this is 3 centimeters. Okay. So straight away, you're looking that there is a right heart strain. There is increased pulmonary pressure. Here, if you keep going down in the direction towards the liver, this is where the IVC comes. Keep looking, and you can see this contrast is going into the liver here. This is the liver, the contrast going into the liver. This is all tricuspid regurgitation. Some of you may turn around and say, why are you teaching us this? Why do we need to know this? You know, we have pulmonary radiologists in the world. They will tell us what it is. We will not be seeing this. The reason I'm telling this, especially for the youngsters who are in training, is that at 2 o'clock at night, if a patient comes in with acute shortness of breath, CT scan anybody can do. You will get CT scans, but if you do not have a good person interpreting this, it may be very easy for you to pick up these things and you can save someone's life by doing thrombolysis. So just a very simple method. All you have to do, start off, measure the pulmonary artery, measure the right heart, and see if there is contrast in the IVC. Once you've done that, now we're going to start looking at this. This is the main pulmonary artery. This is going into the right pulmonary artery. You can see this is what normal pulmonary artery should look like. If you go into the right pulmonary artery, this is the upper lobe, and you suddenly start seeing that this vessel has got this black area around it. You can see this black area around it. And across here also, you start to see this black area. These black area are nothing but thrombi or clots within the pulmonary artery. The same way, if you go to the left side, you can see this is the left pulmonary artery. And within the left pulmonary artery, you're seeing these central hypodense filling defects. You can see this vessel is big, enlarged, and there are these webs within this. All of these are those of pulmonary embolism, acute pulmonary embolism in a patient who has got right heart strain. At the same time, we would look at the lungs of this patient. Okay, and when we look at the lungs of this patient, we're looking for these areas. You can see very nice, sharp, wedge-shaped areas. These are all suggestive of infarcts that we are looking in this patient. Okay, so look for right heart strain, then we look for filling defects within the pulmonary arteries, and then we look for lung parenchymal abnormalities. This way, it becomes very, very easy for us to be able to detect this. And this is what I want you all to do, because at 2 o'clock at night, you're not going to have anyone else help you. It is very useful for you to pick it up and be able to make that diagnosis. Let me show you a different case now. Okay, this is a different case that I'm going to show you. Again, a patient comes in with acute shortness of breath, and this time we are looking at this. So first thing, remember, is to look at the size of the pulmonary artery. And this size of the pulmonary artery here, I'm just going to measure this across here. Pulmonary artery only measures 2.7 centimeters. Then I will measure the aorta. The aorta in this case measures 2.9 centimeters. So the pulmonary artery is not enlarged compared to the aorta. Next thing I'll look at is the right ventricle. So we go down, and we're going to start looking for the right ventricle and see whether the right ventricle is dilated in comparison to the left ventricle. So this is again the right ventricle. We are starting to see the contrast hasn't reached the left ventricle, but what you can see here, this is the left ventricle in this case, which is quite big. The right ventricle is actually not dilated. Okay, the left ventricle is big, the right ventricle is not dilated. And then we are going to look and see if there is any tricuspid regurgitation. So you can see this is the contrast as it's flowing in to the liver. And you can see, yes, there is liver getting contrast, a lot of contrast into the hepatic vein. All of this suggestive of severe tricuspid regurgitation. Now, as an educational exercise, what I'm going to do now is I'm just going to run this video. Okay, I'm going to give a little bit of a time for everybody who's watching to turn around and see what do you think is happening in terms of, is there any clot or not? If there is any clot in the pulmonary arteries or not. So the video is just going to run for you to be getting yourself tested, getting yourself used to looking and saying, am I seeing any clots? If you are seeing clots, where are these clots? Are they in the right side? Are they in the left side? Are they lobar or are they segmental? All of these becomes very important. So I'll let it run one time. As it is running, I want everybody to just concentrate on the image I just want you to look at the image and say, okay, I can recognize it, or no, I cannot recognize it. These filling defects, whether they are there or not. I'll let it run one more time so you get used to seeing what pulmonary embolism looks like. Next, once you have made up your mind, you've decided what you're looking at, the second thing what I'm going to do is we're going to try and score the severity of clots in this case. Remember, each segment we tend to give 2 if it is completely occluded, if it is partially occluded 1, if there is no flow problem, then it's a score of 0. Whatever the score comes, we multiply it by 2.5 to get the clot burden. Okay, so I'm letting it run. The online platform always makes it difficult for the interaction. So just do it yourself, keep it in your mind, see what you have thought, and then I will take you through. Okay, so let's get started. So if you see here, what we are looking at, this is the right pulmonary artery. And as we come into the right upper lobe pulmonary artery, you suddenly start seeing this filling defect. I'll just zoom it in so you all can nicely see that. You start to see this filling defect. So that's one segment gone. So similarly, we will count and see there are other segments. This is another segment gone. So then we look, another segment gone. All of these are how we are trying to basically count the number of segments gone. Another segment across here has got clot within it. You can see towards the mid aspect of the vessel. And as we go up, again, we will look on the left side also. Just make sure we are looking on both sides. I'm just zooming it a little bit out. And now we start to see this is the left pulmonary artery. You can see these clots. This is another clot. All of these are features of acute pulmonary embolism. All of these are features of acute disease where there is severe tricuspid regurgitation, but there is no right ventricular dilatation or no pulmonary arterial dilatation, suggestive of early pulmonary hypertension. So you can see this is what a clot looks like. Okay, this is what a clot looks like. As we go further, you can see this is a normal vessel. These are each segments that we are looking at. And once we count these segments one by one, I've counted this segment in this case, and I have got that 10 segments have got partially occlusive disease. So 10 segments, partially occlusive disease would give me a score of 10 into 2.5 will give me a score of 25. So the clot burden is 25% in this patient. So next we're going to look at, quickly we're going to look at is the lungs of this patient. Okay, we're going to look at the lungs of this patient and we're going to see if there is any secondary features in the lung which will help us to recognize whether there is any thrombus related complications or not, if there are any infarcts. And then suddenly you start to see these changes across here in the periphery of the lung.
Yes.
Again, wedge-shaped area. This is again pulmonary embolism related pulmonary infarct that we are dealing with. So this is what I want you all to remember. This is what I want you all to learn. And in interest of time, I'm going to stop there and leave this message with you. When you start seeing patients who come in with acute shortness of breath and you're suspecting them to have pulmonary embolism, CT pulmonary angiography is the scan to be done. In CT pulmonary angiography, start with looking at the size of the pulmonary artery, size of the right ventricle, look for tricuspid regurgitation, and then go in a segmental manner to look for these filling defects. There are lots of other information which can be gathered in there. Those of you who are interested, if you go to YouTube and type my name, Dr. Vimal Raj, I put a lot of these educational videos there for free. So you can learn and see what are the different causes of pulmonary hypertension that CT can recognize. Again, thank you very much for having me here. I do apologize that I have some other commitments, so I had to jump in and do my presentation here. Thank you very much for having me. Happy to take any questions if we have.